I'm going to go with them just to hang out at the beach. I'm tired.
They didn't get hit too bad with the hurricane, right? I know there was a lot of scare, but it went off the coast.
They're more on the west side of the bay side.
I have a bunch of friends who live in Florida in different areas, and you know, some just jumped ship and because everyone told them to evacuate.
Absolutely.
And others said, you know, I'll help you out, have hurricane windows, and then they only, you know, they had a couple of down tree branches, and that was it.
Yeah.
So,
no, it's chancy though, because
of course.
you never can
I mean,
tell.
look what happened to the Keys.
Just think of the way they are.
They say it'll take a full decade. So
I lived on First Hill, and I didn't get any progress.
but you would assume the power's going to come back in a couple of days.
Yeah.
It's not, you know, I mean, the Keys, there's not much infrastructure. That's the problem. You know, stuff is just
very low lying.
It's all decimated.
Another thing.
I just read an article that people are still living in tents.
Yeah.
You know, having all these issues. So, it's, you know, how do you rebuild from them? It's just a cost.
It is.
Well, at least, you know, here it may rain all the time, but at least you're immune from a lot of the natural, you know, the disasters and stuff.
I'm just reading on my MSN homepage that, you know, there are 5 places where earthquakes can really be bad. Cascadia is one of them.
Really?
We're due.
When's the last time you had one? I mean, we get some all the time. But, you know,
yeah, we've had 3, maybe 4 since I've been here since '66. But we've had a couple. But this one, they say they could be up to
There you go. They won't let us close it.
now, how's the? What's the like the skyscraper and like the buildings from? Are they all built with
The new
foundations
ones
that are meant to
The
shift?
new ones are built with earthquakes. I'm in a new condo on the 22nd floor, so.
You better hope so, right?
Yeah, I hope so. But there's something kind of always run down the stairs. No escalators.
I was actually, we had when I was still living in New York.
What parts of New York are you from?
I grew up in Brooklyn, but I went to this particular instance. Right, and I was in. I remember I was in Beth Israel Hospital at the time, and you could feel just using your share, not a whole lot, but you know, everything essentially meant to handle that. A lot of the New York buildings, particularly in Battery Park, near the Wall Street area, there's no bedrock. That was all built on land. So everything there has a special foundation to support and also handle this kind of shit. So they don't usually run into too many problems, but you know, there still were the buildings. Of course. So
Ramapo is one of the places.
so Ramapo is right outside there. Ramapo is actually, if it's the same Ramapo, it's in New Jersey, it's right outside of New Jersey. Really? I did not know that.
MSN Home is one I have.
We can't park anymore.
So Ramapo was just a nice sort of suburban area, you know, not too much going on. But now housing has become insane everywhere in New York. And so all of these, you know, like nothing areas in Jersey have become huge too. And so
They're always in community distance.
and they've become just the sheer cost of it is basically nuts. Not that it's any better here, but it, you know.
Well, it's a little better here, but it's not. You know, this is the best. This is the highest. What is the word? Fastest increasing value of real estate.
As long as tech stays hot, and it will.
Drew, the tech guy was here. Did you see him?
Oh, I didn't know.
Okay, he came down just to hang out to make sure everything was okay.
Looks like it's working.
Yeah.
And then, is there any way I'm supposed to be facing, or just anywhere I want? It'll get me any direction. I assume it'll be tracking movements and things. I usually like to use the mouse.
I like the way they go for it.
Yeah, it works. It's working so far. So it hangs a little.
I can never get
You know, I was like someone forwarded it to the nervous.
Try some cherry jam. You and us.
Yeah, the Westchester area, absolutely.
By the time I
It's funny. I never.
yeah, no.
I can't recall, at least as the first time in recent memory.
They're trying to get it going.
Going to despite living in New York all my life. And I left New York, and I went to Chicago. I ended up flying to Tarrytown because for the General headquarters were in Tarrytown. And so I was like, oh, that's funny. I ended up seeing this place for the first time only after I actually, I flew in at that time. I think I flew into LaGuardia. I just took a long drive.
Patients, yeah, they're bummed about it.
Now I've sort of gotten spoiled. I'm forgetting what traffic is like. It's hard for me to ever sort of go back to that.
Yeah.
Especially in New York.
Make a difference for our staff.
I know.
I was doing 65 miles an hour on the highway, and he's like, give me a credit card, I want to swipe it now.
They said, driving in New York, I had an old and I would play a challenge. I'm sure you're an average, they try to do that. It's an old car, just stay right.
Those old tanks.
No, the funny part is we're the only one or two houses in our neighborhood.
In New York on Sunday. Actually, we just crammed. I got into Uber, but I was just looking for a cab, and I was going to miss my flight, so it was available. Oh yeah, I'll just look up what the Uber rate is, and we'll do it that way. Well, then it looks like the Uber backwards, which is double cost. The guy was pulling all kinds of games, but it's like, then they get you, you're stuck. And the guy was
I got here a half hour early.
and I'm not exactly a passive driver. I haven't lost that justice by the aggressive driving. But they are. And we're doing about 65 miles an hour on the highway. Approaching LaGuardia, he wants to get close to it. So he's driving with his knees, and he's swiping. I'm like, you're crazy, you're going to get me killed.
I know.
No,
it's definitely a change.
Right outside of the airport. I need to take
They won't let us close.
He got me the on here, so.
He just came down, did you miss him?
It's all right. Yeah.
Okay, he'd be
Can't
right
do
back.
it, and they have no one here now.
Yeah, he said it's
A lot of regulations here.
check, you know.
Or transplant.
About ready to head to Hawaii.
He's
Other
doing
than
great.
We got
transplant.
another month.
Well, that's the Western Society. I have a house there. I have a house on Kauai. Or some hiking with Australia. Hawaii is a national place.
Hello, doctors. Oh, I got new eyes, new ears. Yeah, I did.
That's all right. I spent like 30 years.
Do I realize you're
I wish it was my brother is also in finance, and
You haven't had one yet.
I tried pushing to
I don't know when you first started realizing you're going to get cataract.
and salary. So it's something remarkable thing.
Absolutely.
And I had already planned an appointment with my eye doctor today.
But you see now, it's not like inequity is.
You know, I didn't realize that when
unique to
you
that sector.
kind of when you're looking at flights, especially at night.
Yeah, you get the halo.
That's what I
I
think.
mean, I'm sure I'm not sure I could take it. What do you do now? Fortunately,
He has a friend that the person who's on call.
Yeah, I had LASIK. I did LASIK, so that's why I don't glass.
First, like non-communicable disease, that's really trying to find out.
It was
You know, what's fascinating, I saw an interview years ago when 60 years ago.
That's the only thing that's a little disturbing.
I was up before.
You know, he's got a 24-hour section.
Did you get any power out of it?
You know, it didn't last. We never lost it all. We're a heavily screened area, so.
Yeah.
Although we don't, all the powers underground.
Sure, it's working like that.
But all the
No.
Maybe even like 20 million. That's fine. You know, like, what do you do for $50 million?
I got it generated.
Right now he's beat him.
I got it. Just went out.
Yeah, I know.
So they just broke it. I know.
Just control everything.
You hear about this? What? Exactly. I know. You might get hurt. Well, and then I work at Preventive. I've done it. I was in touch. Well, I don't like the idea of having it nice and wide open. Just leave it like that.
And they booked it for me. It's not the biggest thing. It's just that.
Oh, they booked that side? And they're making us pay for it?
No.
Oh, I thought maybe it's really safe to pay for it.
I know, it's like, what if you like?
Are you going to Rizzy this weekend?
No.
That's a tough thing also.
Are you?
One thing you're buying.
No, I got the game.
It's another thing
You
you're
know,
buying.
it's a 7:30 game. I don't know if I both rest of the wind is really, you know, if the wind was like it was last night, we were going to go. If the wind's over 10 miles an hour, we might not go. But otherwise, penalties coming down, cross coming over, the usual suspects. So.
How's the next couple weeks look?
Sure. No, we were out at Whitby this weekend.
Now Amazon wants to go for the
I just asked your dad what's happening with this. Did he adventure anything?
No, I haven't heard anything. So you know what, I was going to call him this week. Although my brother-in-law, who is familiar with the media because he's in Colorado, he sent me an email about there having some financial problems.
Yeah, we just had to lay off a bunch of people. It's the same thing as
Yeah. That's nothing unusual. That's just the business, right? Yeah.
Unfortunately, they...
And so I didn't, you know, I kind of took it as great.
12 hours.
Have you guys got another kid? We're happy.
Fine.
Yeah, obviously, they're not going to wait.
I'm going to be leaving. I talked to the guy
Just to get there.
She's like, oh, like,
Used to
he like look into it, and I got home at like 7 o'clock on Friday, and like the bed didn't show up.
So maybe
Central California. His name is Joe Mello. He's the chief operating officer.
are all of them?
You know, I'm embarrassed that that doesn't sound familiar. That's not
He's
the
not the
guy
guy
talking.
negotiating.
Yeah, right.
He's their CLO for Davita in general.
So that other
He's
one.
moving up, but he actually he started by managing allergy practice.
You know, I did look online. There was
Wow,
$1
fun
billion.
time.
Those big companies that make small potatoes. They're like 20%.
Now it's really started, right?
Troy was like, I don't remember his
That's how my brother-in-law
name.
was Good morning. Made it, huh? He got up out of bed, huh? Good for you.
He's doing much better.
Do you want to do transplant?
We expected a big crowd.
It looks bigger already just because the room.
No, he can't
They're
be.
spreading
He
out
can't
to the other room.
You're afraid Drew's gonna get, you know, an injury.
I know. Probably like clam against the university.
Well, you know what?
My back's hurt.
He is kind of a wimp. Oh, there's so many regulations. It's absolutely crazy.
Just living the dream.
Oh, good God.
It's not bad though. The people, the overflows go over there. So.
They did both the other side of
Yeah,
it.
yeah, yeah.
I just wonder when they're going to finally quit building down here. We
Yeah,
counted
so we can get a
16
parking
trains on
spot.
the way in.
This is crazy.
Terrible.
I'm 5 blocks away. I drove around about 3 times.
You know, down here on whatever that street, 9th, they put there's a bike trail, but then there's parking in that little
Yeah,
strip.
I went by that and wondered, and I didn't go there because I wondered. So they got this, you know, these white posts.
So the bike path is,
Yeah, okay.
know.
Is that where you park?
yeah, for the last 3
Well,
weeks.
now that I know that,
I haven't gotten a ticket.
I didn't know that because I haven't had to go there, but I'm parked across the street from that.
And that little space that we normally park in, there's a big track code there and a bunch of junk.
And the construction workers get all these here. They're out there.
I know, we will.
You beat them?
How are your
You're on the
Wednesdays?
street?
Your Wednesdays
Well,
are
I was here at 6:25. You know, I get here this early because I want to get a parking. I couldn't find it. I drove around the block 3 times.
Skin.
Oh, skin.
Don't be so superficial. There's a lot of good jokes in there.
Anybody in the room not have power at their house?
I don't.
Yeah. It's not a lot of fun to get up in the morning with no power.
You have hot water though, don't you?
You know, I didn't use much.
We knew that. No, I shouldn't do that.
First fellow. And it's still a pain in the ass.
So you're the heckler in the audience. There's always got to be
Well,
one.
somebody has to keep him honest, you know.
You may wonder why the other half of the room is open. We usually close it. It's a new regulation. Somebody can hurt themselves pulling the partition out, so it's against university regulations for Drew to be able, or any of us, to be able to
I could hurt myself.
get hurt and sue the university. Anyway, the word of the day is skin. And I'm very pleased to introduce Jonathan Silverberg, who's come from, actually you were in New York, you said, but resides in Chicago, but grew up in Brooklyn. And he's going to give us a talk here on comorbidities of inflammatory skin diseases. Jonathan, thanks for coming. Sure.
So, just to give a little context, a little background, I am all inflammatory all the time. I'm one of those rare dermatologists that almost never does skin checks anymore because you know, we deal with all the complex medical dermatology cases and inflammatory cases. And what I want to, you know, have you walk away sort of with a sense of at the end of this is really understanding that I think concepts that we're seeing more and more, not unique to one specific disease, but really a broader theme within the realm of chronic disease epidemiology and within inflammatory skin disease in particular, about the systemic aspects of these disorders and recognizing that the implications of these diseases go well beyond just the visual aspects on the skin by itself. These are my disclosures. None of these are going to be relevant. We're not going to be talking too much about therapeutics, but really understanding the disease states themselves, although there will be some mention in passing of certain medications, nothing branded or anything along those lines. So, just an overall summary, we'll break things down by the comorbidities themselves, by the different systemic or extracutaneous complications, if you will, of the different skin disorders, and then sort of give you a potpourri or a sampling of some of these different disorders. Now, so the sort of four overarching categories will be neuropsychiatric, autoimmune, allergic, and cardiovascular. And many of these disorders, we'll see, will involve the atopic spectrum. And so these are going to be topics that are going to be near and dear to the audience's heart. But some of these are going to be sort of classic immunological disorders that you may not have seen so much since your training. And some of these may be less commonly encountered skin disorders, but ones that you'll see really may overlap tremendously in terms of their immunology. So for neuropsychiatric, there's sort of three broad areas to think about. One is sleep disturbance, and then mental health, and then other sort of neurological disorders. And I put sleep disturbance as a sort of standalone category of neuropsychiatric complications because, as it turns out, the complexity there is really quite impressive. When we think about sleep, and we'll talk a little bit about atopic dermatitis in particular, but when we think about these, often we're thinking about, patients are itchy. And so when they itch, they don't sleep well, or, they're wheezing. So in the case of asthma, and that's why they don't sleep so well. But it turns out it is far more complex in terms of patterns of circadian rhythms and things like that. And we've really, pardon the pun, but we've just sort of scratched the surface with this in terms of understanding this complexity. But it's really an area that's becoming very hot now. So for sleep disturbances, we'll start with just the basics within atopic dermatitis of how common sleep disturbances are within the adult population with atopic dermatitis. And these are some data from 2012 National Health Interview Survey, really actually one of the only, in fact, to my knowledge, actually not the only, but one of the only U.S. population-based studies available that assessed prevalence of atopic dermatitis and allowed us really to understand some of these comorbid health conditions. And so over 34,000 households assessed and representative of the U.S. population. This is Congress's data arm, if you will, to understand the health conditions in the United States. And what you see in the blue bars are those with eczema, and then the gold bars those without. And I don't know why it's interesting. It doesn't project here. Interesting. But what you can see is clearly that those who are reported to have eczema have higher rates of fatigue, daytime sleepiness, and insomnia compared to those without. When you actually look at the numbers, you're talking about anywhere between 25% to 1/3 of that, across the U.S. population of adults with these reported sleep disturbances. What's intriguing about this is that we anticipate the overwhelming majority of these cases to be pretty mild and to probably not even get in to see a dermatologist or an allergist. And, maybe they get into primary care, maybe they're self-medicating on their own. They can, they're the milder ones who can use over-the-counter treatments. And despite that spread of being predominantly milder disease across the population, you still see profound sleep disturbances that occur. This is a very complex figure, and I'll try to walk you through very high-level overview, but it's a summary of something called latent class analysis, which is basically a glorified factor analysis or clustering analysis for binary variables. And when you throw in some of the different atopic comorbidities, so eczema, asthma, hay fever, respiratory allergies, digestive allergies, and then these three different sleep symptoms, fatigue, daytime sleepiness, and insomnia, what it actually pulls out is 5 different latent classes. And that's there's just the way these cluster together in patients. And you can see that there's a little bit of a spread. You have here in group 3, a group that clearly has lots of sleep issues. They have high probability of the fatigue, sleepiness, and insomnia, but they don't really have too many issues related to the atopic dermatitis. But instead, they have more problems with respect to other things that may be dealing with this, other chronic diseases that might be potentially driving this. And then you get to, let's say, group 4, where you can see, and I'm losing the mouse there for a second, but you can see a higher probability of atopic dermatitis here, and you also see the comorbid asthma, hay fever, etc., and with those symptoms, strong probability of the sleep issues. But you also have a group, which is this group 1, which has also a high probability of atopic dermatitis and a lower probability of the asthma, hay fever, etc., and still a substantial probability in terms of insomnia and some fatigue as well. So what you're seeing is different patterns. The sleep issues can be really driven by many factors. Obviously, there's a sleep disordered breathing in the asthma and the hay fever, but a lot of this can be related to the skin in of itself. And so when you look at, so why do we care? Why is sleep such an issue that we even need to be thinking about this? And the big issue is because arguably sleep is the most important endpoint in probably all of these disorders. When you're thinking about quality of life. So this is just looking at the interaction between atopic dermatitis and sleep disturbances and its impact on the proportion of patients who report having only poor or fair quality of life versus those who have excellent or very good overall health. And what you see is that in this row here, these are those who have no fatigue but report having eczema. And you see a significant increased odds in the, this poor or fair health. But it's not a massive effect size. When you get to those who have sleep issues but no eczema, right, because sleep can be disturbed from pain and many other things, not surprising, you see a big boost, or in a bad way, in terms of having only poor overall or fair overall health. But when you have both, you have this synergy where those who have the skin disease plus the sleep issues get even worse in terms of their poor overall health. And when you get to that group, you have almost half reporting poor or fair overall health. So the sleep by itself, even when you're not, sort of taking into account of the whole spectrum of itch and everything else, the sleep by itself is a very important proxy of poor quality of life. And we found similar interactions with the other symptoms of sleepiness and insomnia as well. It turns out there's a little more complexity there. It's not just a symptom that's related to the itch. And here's where we start to see a little bit of different signals about sleep disorders as being sort of standalone disorders that we need to think about. So this is a study from a retrospective analysis from Taiwan's National Health Insurance Database. It's a great data set to look at because it's a single claim, all claims data set for the country, which is one thing that we've lacked, unfortunately, in the US, which has made it very hard to do some of these kinds of analyses. But they sampled 1,200 patients with obstructive sleep apnea and matched cohort of 18,000 without obstructive sleep apnea. So this was using that case control design.
and then looked backwards to see what were the preceding rates of atopic dermatitis. And what they found was that the incidence of obstructive sleep apnea was significantly higher in those with atopic dermatitis versus those without. So about 9.8 per 1,000 versus 6.2 per 1,000 in the non-atopic dermatitis group. And so the risk was significantly higher, and particularly more common in males and younger patients. Now, what's fascinating about this is there's a number of issues that are interesting about this. But we used to think that obstructive sleep apnea was a unique sleep disorder that would happen in psoriasis, which is another inflammatory skin disorder, where you've seen lots of literature about obesity and cardiovascular disease, and we'll talk a little bit about that later. And for a disorder like obstructive sleep apnea, where we think so much about excess adiposity as a driver, we're seeing similar signals here, and so it already sort of hints to that. But even in the Taiwan population, which has far lower rates of obesity compared to the U.S., you're still seeing these signals. I don't know if you saw, there's yesterday there was a report from that would suggest that you should reclassify high blood pressure, would put the U.S. population at being almost 50% with hypertension. You have about 40% with obesity. So we're a very fat society overall. Taiwan is not, and still you see those signals in terms of obstructive sleep apnea. So what are some of the things that we see? For adults with atopic dermatitis, this is looking at just the summarizing data from National Health and Nutrition Examination Survey, but we've seen this across many clinical cohorts. Higher rates of trouble falling asleep, early morning awakenings, feeling unrested, feeling overly sleepy, a sense of not getting enough sleep, and then very interesting at the bottom here, leg jerks during sleep and leg cramps during sleep, which of course is what we think about when symptoms of restless leg syndrome. And so we weren't able to probe, actually based on the diagnosis, these patients actually did have a non-significant, it wasn't enough power to really show significance, but these patients seem to have more diagnoses of restless leg syndrome as well. And so all of a sudden, it's not just about fatigue because they're not, because they're itching. All of a sudden we're seeing other signals in terms of obstructive sleep apnea, restless leg syndrome. And so what were these associated with? Well, these different sleep disturbances were associated with challenges and difficulties concentrating from being tired, difficulty with remembering things, eating, even taking care of activities of daily living like hobbies, getting things done, even finances and stuff at work. So many, many, many impacts in terms of quality of life. Now I'll switch gears and we'll talk about, just to show you that this is not unique to atopic dermatitis. So I want to sort of give you a sampling of other disorders where you get to see this as well, and we'll try to come up with some potential common hypotheses for why these happen. So for sleep disturbances in psoriasis, psoriasis has been hot in dermatology now for over a decade now, because with the advent of biologics in the field about 15 years ago, there was all of this renewed interest in psoriasis. And all that attention had led to a lot more research in the disease, far more so than what we have available yet in atopic dermatitis, although I think that atopic dermatitis will enjoy that renaissance as well now with this very active pipeline of pharmaceuticals. So this is a meta-analysis of 32 different studies that examined sleep in one way or another in psoriasis. And of those, 30 out of 32 observed at least some sleep disturbance present in psoriasis. And a variety of different study approaches. Some actually did full sleep studies. Some were using more validated questionnaires like the PSQI. And there's a number of different strategies that were used. What's fascinating is 4 studies found higher rates of obstructive sleep apnea, so pretty high rates of that. Not surprising. This is a group that is known to be obese and have higher cardiovascular risk. But what's really intriguing about this is, and we've seen this from the sleep literature, that sleep disorder was associated with higher cardiovascular disease in one study. And so this already gives us just a little bit of a hint, but for the sleep specialists, they've been dealing with this for a long time. Sleep is arguably the most important predictor of cardiovascular health, and mental health for that matter as well, within chronic disease. It is a very important predictor in terms of adiposity, blood pressure, etc. So when you have patients with these chronic sleep disorders, there are going to be downstream effects of that. And that's not unique to psoriasis. That's going to be an issue that you're going to see any scenario where you have these chronic sleep disturbances. Mind you, just for full disclosure, I'm a hypocrite. I'm a workaholic, so I don't sleep very much. But it's my self-imposed choice. I always say that I'll probably live the same number of waking hours even if I've lost longevity in years. That's probably not something to joke about, but but it's something that you have to recognize. This is a well-established phenomenon that impaired sleep with less than 6 hours or more than 9 or 10 hours on average is actually associated with far shorter longevity. So let's talk about vitiligo. And I want to show you the vitiligo for a number of reasons, and I'm going to come back to sort of summarizing all of them. Because vitiligo is mostly an asymptomatic disorder, right? So I started with the most symptomatic of the skin diseases that we'll talk about, which is the atopic dermatitis. Intensely itchy, lots of skin pain, many reasons why those symptoms will secondarily impact sleep. Psoriasis is a far more cosmetic disorder. There certainly can be some pain, there certainly can be some itch, but that's not nearly as bad usually as atopic dermatitis. But then you get to vitiligo, where there's certainly a subset that can have a little bit of itch. But by and large, this is an almost exclusively cosmetic disease. And still, despite the fact that it's relatively asymptomatic, we actually see a number of sleep disorders that are just demonstrated, but a different pattern. And it's fascinating to start to see different phenotypes of sleep issues that come up. So this is just one study that examined a cohort of vitiligo, other dermatologic disorders, and then healthy controls, and found that those suffering from vitiligo reported higher occurrences of parasomnias in terms of sleepwalking, nocturnal enuresis, night terrors and illusions, and nightmares. And we see parasomnias in atopic dermatitis as well, or at least case reports of it, where patients will dream of itch and scratch and wake up in the morning having scratched themselves, and this concept of it literally plagues them in their sleep as well. But we're seeing this, that a number of different altered sleep disturbances that happen here. Mechanisms of this particular one are fascinating because the symptoms are not major drivers here. So there's something quite unique probably about those inflammatory mechanisms and the immune synapses that drive a lot of this. Alopecia areata is another one that is relatively asymptomatic. It's in fact almost exclusively asymptomatic. Alopecia areata is the one where they get the autoimmune patchy hair loss. It's usually cytotoxic T cell infiltrate that attacks the hair bulbs and causes this patchy hair loss. But it's one that it's really, the inflammation happens well below the area where the cutaneous nerves are. They shouldn't feel anything for the most part. So it's really a cosmetic issue. And what they found was that patients suffering from alopecia areata in this particular study did not have higher rates of excessive daytime sleepiness, no correlation with disease severity, no correlation with pruritus during treatment. And so here's one where we're not seeing any of those major issues. Now, what's the difference between alopecia areata and vitiligo? We don't know. I mean, this is something that really raises some fascinating questions, that there may be very, very distinct profiles that are specific to these different disorders. So how do we put this all together and try to understand this? So certainly for those disorders that are symptomatic, the itch-scratch cycle is going to interfere with the initiation of sleep. It's going to wake them up in the middle of the night. It's going to make them hard for them to sleep. But we're actually starting to see now some fascinating research being done. There's actually a group now that at Northwestern that are trying to do this, I'm collaborating with, to try to understand circadian rhythm regulation of inflammation and regulation of itch in particular. And it's really, I mean, it's been established now that there's circadian control, even of IgE levels within a single day. But we certainly see this in terms of lymphocyte levels, etc. Inflammatory cytokines will vary during different times of the day, and there may be a circadian rhythm wiring where there may actually be an upregulation of symptoms, and particularly of certain inflammatory cytokines in the evening compared to the daytime. We know about specific inflammatory cytokines that are implicated in sleep regulation, particularly interleukin-6. And an interesting issue that comes up here is that for those patients with a lot of these heavily symptomatic disorders like atopic dermatitis, if they've had it for 30 years of their life, you can bet they have some really bad sleep hygiene and really bad habits when it comes to their sleep. Because they fall into the trap that when they wake up in the middle of the night and it's hard for them to fall back asleep, they do the worst thing possible, which is they'll pull out the iPad. Nowadays, the younger folks pull out the iPad. In the old days, they went to the Home Shopping Network and just went, turn on TV at 3 in the morning. So it is not uncommon for my middle-aged patients to get into trouble with literally binge shopping in the middle of the night because of this issue. And it's funny how even when the eczema is well controlled, some of those bad habits don't die because now it's become habit. And so really working with trying to improve sleep hygiene and sleeping patterns is very important. And it may be outside the scope of our traditional practice in dermatology or allergy, but it's something that you can definitely refer to the sleep specialist to address these things. And then a big one that comes up is medication use. Because we use very commonly, certainly in the world of allergy, but even in dermatology, we use lots and lots of antihistamines to try to at least sedate patients short-term through their itch, or perhaps they have some benefits with itch and atopic dermatitis, or certainly for carrion, for other disorders where it's directly targeting a causal mechanism. And yet it turns out from a lot of the data that long-term chronic use of antihistamines actually will disturb and mess up the circadian rhythms and mess up long-term sleep cycles and disturb REM sleep. Same thing for systemic corticosteroids. Systemic corticosteroids are murder on sleep patterns, especially with chronic use. And so they may be a necessary evil, but there may be a lot of untoward iatrogenic effects that we have to think about. And so there's a lot going on here. This is going to be a multifactorial process, but one that you really want to be thinking about and trying to address in terms of clinical practice. So let's talk about mental health. So for mental health, this is just a summary of some symptoms that are reported in children with particularly atopic dermatitis. So fussiness, irritability, crying, clinginess, fearfulness, co-sleeping, which is when the parents are stuck, having the kids sleeping in their bed, and the impact on the family as well. And then frank symptoms of anxiety, depression, and ADD, ADHD. And what's interesting is that we're now learning that these are not just loose associations of two sort of independent disorders, but these are actually direct symptoms of the disease. And when you improve disease control, many of these actually get better, but not always. And we'll talk a little bit about that from a study that was just published last week. I didn't get into the slides in time. But this just looks at the proportion of patients with mental health disorders throughout the U.S. population, again in blue with atopic dermatitis and in gold without atopic dermatitis. And again, you see significantly higher rates of all of the mental health disorders examined in those with atopic dermatitis and those children with atopic dermatitis. This is from the National Survey of Children's Health, 2007-2008, which is also a very well-done telephone-based household survey, and using validated questions for both identifying atopic dermatitis as well as for severity. And so the prevalences were higher for all these disorders, but you see a dose response with severity of disease. And for those with severe atopic dermatitis, 14% with depression, 16% with anxiety, more than a quarter with ADD, ADHD, and more than 22% with conduct disorder. And what I want to point out is this is not self-report of these disorders by the caregiver alone, meaning it's self-report of physician-diagnosed disorders, meaning the physician may have overdiagnosed it because it may be a symptom of their atopic dermatitis, but in fact these are patients who are being treated as ADD, ADHD. These are the ones who are getting put on Ritalin. These are the ones who are getting treated with different medications, and in fact a lot of this may just be symptoms of their severe atopic dermatitis, and something that we, treating the skin disease, can actually impact and improve and reduce down the road. This is just
percentage of the
sure.
Those are boys versus girls? Because you always think of ADD and conduct disorder. So what percentage of severe eczema is more boys versus little girls?
I don't remember in this particular cohort. We actually did a study looking at 19 different cohorts throughout the U.S., pooling together all the available data for National Health Interview Survey, National Survey of Children's Health, children, adults, etc. And across those cohorts of those, or that subset of patients who have been reported to have ADD, ADHD, there is a predilection for boys. There's a predilection for obesity. There's some sleep disturbances, many other things that may drive this. But it's not all boys by any stretch of the imagination. I think it's only about 45%, or 50, maybe 55% boys, 45% girls. So you see an effect, but not like a 5-fold increased odds. It's more like a 1.5 increased odds type of scenario. So these are some data from the German population, also from childhood, showing a clear-cut association as well. Not a massive effect size in this particular cohort, although this is a claims-based cohort, so there may be some limitations to some of these definitions. And but we see this internationally as well, and throughout. In terms of other psychological disorders, this is a great study that was done, a multi-center study throughout Europe, that tried to really assess the burden of skin disease and mental health or psychological comorbidities that happen throughout many skin disorders, but found that within atopic dermatitis in particular, significantly higher rates of depression, anxiety, and suicidal ideation. In the U.S. population, these are some data from the National Health and Nutrition Examination Survey, found that about almost 1 in 5 adults in the U.S. who meet definition of atopic dermatitis, meeting the SIG-CAPS criteria for major depressive disorder, with more than 10% having moderate to severe depressive symptoms based on the PHQ-9 score. And similarly, when you look at National Health Interview Survey, which is self-report of physician-diagnosed depression, again, about 1 in 5 adults with atopic dermatitis who are reported to have a physician-diagnosed depression. So very high rates within that atopic dermatitis population. Well, again, we'll try to come back to some shared mechanisms and concepts to be thinking about here as to what drives it and hopefully some clinical relevance. For psoriasis, we have a systematic review that was done over 32 studies, and psoriasis was associated with higher rates of anxiety disorders, eating disorders, mood disorders like depression and bipolar disorder, personality issues, schizophrenia, and then sexual dysfunction as well. And none of these are necessarily specific to psoriasis. We're starting to see these patterns that really across the whole spectrum of chronic inflammatory skin diseases, these mental health issues come up. Again, similar idea, vitiligo, alopecia areata, less symptomatic disorders. We see a different pattern, but we see patterns of mental health issues that come up as well, anxiety issues that come up, issues in terms of self-consciousness, and symptoms of depression and anxiety as well in different studies. And in one study of alopecia areata that was a large-scale, well-done study, 1/4 had mental health problems, including anxiety and depression. And so less common than psoriasis and perhaps atopic dermatitis when you look at sort of comparisons between these different diseases, but clearly more than the rest of the population, and really something that is an important driver of quality of life and overall health. So where does this come from? So, we'll talk about some of the shared mechanisms at the end, but this is going to really be a multifactorial issue as well. Some of this is largely going to be a druggable issue in the sense that it may not be a single target, but it may be, a byproduct of poorly controlled disease. And so when we have patients with these mental health symptoms and these mental health burden, we really need to think about, all right, even if, their skin disease may look relatively well controlled, but if it's really that bothersome to them, that they're getting into these problems, that it's sort of an indication to step things up and to execute to a stronger treatment, maybe a systemic agent, and depending on the scenario, if it's available. For many of these, we don't have systemic agents that are available. But a lot of this is really part of sort of a broader issue of chronic disease epidemiology. And the idea that, we see this with rheumatologic disease, we see this with many other chronic disorders, that when patients have a chronic debilitating disease, it really takes a massive toll on mental health. And so it may not be necessarily a shared pathway issue, but when it comes specifically to ADD, ADHD, depression, anxiety, etc., there is some fascinating research, both in animal models and in humans, that are translational studies that have shown a role for chronic inflammation of different pathways as being potential drivers, particularly with ADHD, but in that sort of that neuroimmune synapse. And it really raises some fascinating questions of, when we treat these disorders, we often will treat with skin-directed therapies because there's a perception that, you have minimal absorption with a topical steroid or a calcineurin inhibitor or whatever it might be, and so always go with safety first. But in fact, you may only be treating, scratching the surface, you may only be treating the surface of where there may actually be raging systemic inflammation for all of these disorders of different pathways and different types. And so this is an area that we need to understand a lot more of because, you fast forward 150 years from now or 100 years from now, when hopefully things like systemic steroids will be gone and you'll have actual medications that work as well but are safe. There may be a real reason to never use a topical medication again because you want to actually treat the systemic implications of the disease. I don't think we're anywhere near there yet, but it's something to really think about down the road. So let me talk about neurological disorders. So this is one that just really raises some interesting and provocative and really raises food for thought. So we looked at an analysis of 19 cohorts, again, National Health Interview Survey, National Center of Children's Health, and Haynes as well, looking at a large number of subjects here, over 300,000 children and adolescents, trying to understand the relationship between atopic dermatitis and speech disorders. This has been shown to an extent with asthma, some challenges in terms of that may be potentially related to inhaled steroids, but may also be related to the fact that airway disease itself may impact in terms of the muscle of the tongue, language, etc. But what we found, at least in the children that I see, is that for many of them, they run into some of these sort of, in a broad sense, language issues and developmental issues that come up, even in the absence of at least demonstrable airway disease. And so we really want to probe that more and see if this pans out. And what we found was that actually significant associations between atopic dermatitis and speech disorders in all 19 studies in the bivariate analyses, and even after you control for the kitchen sink of potential confounding variables, in 12 out of 19 studies it held up. And when you pool across the studies, you have basically a doubling in the risk of speech disorders throughout children with atopic dermatitis versus those without. And when we examined severity, perhaps not surprising, but intriguing, to show that severe atopic dermatitis was actually associated with even higher odds of these speech disorders compared to those with mild or moderate disease. And that's true even after you control for the comorbid airway disease. So it's fascinating that this, this link, and this is one that, again, we can only speculate as to mechanisms why, and we'll discuss a little bit of this. But I want to talk about this topic, which is epilepsy. So this is actually driven, this whole project is driven by my PhD work. So I actually did a PhD in neuroimmunology. And I always say if I didn't become a dermatologist, I would actually be an allergist. And that's actually before I even thought about dermatology, that's what I was contemplating. And we were studying a mouse model of seizures and studying the immune responses that happen afterwards to try to understand this concept of how one seizure begets another seizure and can eventually lead to a chronic epilepsy. And what we found was that there's remarkably, after seizures, even in inbred mouse strains, you actually have an upregulation of Th2 inflammation present in certain areas of the brain, again, mouse brain. And actually, we were able to reproduce a small upregulation in terms of Ig class switching, particularly to IgE, which was exceedingly provocative. And this is published in the literature in mouse data. So he said, well, if there's a connection there, I don't know the chicken or the egg necessarily in real world data, but we wanted to see if this actually holds up in terms of allergic disease and epilepsy. And what we found, so we looked at, these are data from the National Survey of Children's Health that allowed us to look at any atopic disorder, ever history of asthma, current asthma, eczema, hay fever, and food allergy. And of course, we always know you have to take that self-reported food allergy with a very large grain of salt, or like a mountain of salt. But for the other ones, certainly there's demonstrated validity for these questions. And you see very clearly across all of them significantly higher odds of epilepsy throughout all of these different groups. And so, eczema is not the one that necessarily has the largest effect size, but it's one that we really see across the entire spectrum of atopic disease. This may be a very specific mechanistic issue, and other studies have suggested this and have seen some of these connections as well. And it's an area that, again, as we start to unravel that whole neuroimmune synapse and the impact of chronic inflammation on the brain, I think we're going to start to understand this a lot more. When you look at severity, you actually see it's in particular those with moderate to severe atopic dermatitis in particular that have that increased odds of epilepsy compared to those with mild disease. So you see again that sort of dose-response effect with the severity of the disease. We then looked at adults as well, sort of as a confirmatory study, and we just published as a letter to the editor in Jackie, and found also across the spectrum of atopic disease significantly higher odds, about a twofold higher odds of epilepsy in those with eczema, even after controlling for a ton of confounding factors, significant increase. It's not like every patient, right? You're not seeing an odds ratio of 200. You're seeing an odds ratio of 1.37, so it's a smaller effect size, but it is highly reproducible and it is there. And so this really raises some intriguing questions of the chicken or the egg. Is this something that's modifiable? Is this something that when you treat the allergic disease and get better control that you could somehow prevent this? May very well be. It's going to be a hard study to run because you have such a, it's a rare event in general for people to develop epilepsy, so you'd have to run a cohort that is so overpowered and then prospectively treated. with, and it's hard to maintain control in general for long term across a lot of these disorders. So it's something that I don't know if we're going to have the answers from prospective data anytime soon, but we actually will see some more retrospective data coming, and there's some that's already in submission or already recently published as well. So I want to touch upon also some interesting stuff that's coming up as well. This is one that is going to be less encountered in the allergy space, but one that really raises some fascinating discussion points around specific disease associations, and that's rosacea. So rosacea is, it can be an intermittent or chronic acne-like eruption on the face. Often they'll get profound facial flushing, and it's typically thought of as being mostly a cosmetic disorder, except a lot of patients will have actually intense stinging and burning and difficulty tolerating topical medications. You'll actually get, for any of you who do patch testing, oftentimes these patients will get patch tested because they have a facial dermatitis. It's hard to distinguish, and so it's something that you're going to be reckoning with in the differential diagnosis. But this study looked at a large-scale population cohort from Denmark. And so in Denmark, they have also an all-payer data set for now over almost 30 years, which is, and they're far more advanced epidemiologically than we are in the United States for that reason. And so they looked at about 68,000 rosacea patients and over 5 million non-rosacea controls, and found an almost doubling of the incidence, or actually more than doubling of the incidence, of Parkinson's disease in those with rosacea compared to those without rosacea. And part of the plausibility here was that rosacea is thought to be, at least in part, a neurovascular disorder, where the blood vessels are just too jumpy, and they're actually dilating and causing a lot of that inflammation to occur, and that this kind of neurovascular dysregulation might be happening not just in the skin, but in other parts. And so it's not just an interest in Parkinson's, but in other neurocognitive disorders as well. And when you look at the incidence, particularly in those, it depends on how you define it. Based on physician diagnosis is the first one, but if you look at those who are actually being treated with anti-Parkinsonian and dopaminergic drugs, you also have a doubling in terms of the incidence of Parkinson's disease in the rosacea group versus the non-rosacea group. And this is true even after you control for a variety of different comorbid conditions and socioeconomic factors. Now this gets you back maybe into your training. I don't know how much of this everyone has a different practice setting in terms of what they encounter, but autoimmune blistering diseases, particularly pemphigus and pemphigoid. And so these are some data that we looked at from an inpatient cohort called the National Inpatient Sample throughout the United States. And I know it doesn't project very well, but what you actually see are significantly higher rates of dementias, particularly vascular dementia, senile dementias, schizophrenia, depression, bipolar disorder, you name it, across the entire spectrum of both psychiatric disease and then neurologic disorders, including MS, and epilepsy. You're seeing significant associations across the board, and it's true more so in the bullous pemphigoid group, which is up top, but you're even seeing some of these issues come up in terms of Parkinson's disease, other neurologic disorders as well in the pemphigus group, which will often be a younger patient population, but this is true even after you control for age and etc. And so again, this idea that this is something we see across the board throughout chronic inflammatory disorders. So with bullous pemphigoid and neuropsychiatric disease, there's actually a meta-analysis that was recently done that showed that patients with bullous pemphigoid had higher rates of all neurologic diseases, stroke, Parkinson's, dementia, epilepsy, and multiple sclerosis, and some pretty whopping effect sizes. I mean, it's rare that in epidemiology studies you see effect sizes like, a relative risk of 12. That's a strong demonstration, and these are studies that really show that the autoimmune blistering disease precedes the onset of the neuropsychiatric disorders. And so it's not, you can't argue causality per se, but it really is suggestive of it. So what's the mechanism here, and what can we be thinking about clinically that can be relevant and useful in terms of clinical practice? So one, it would seem that the inflammatory skin diseases might upregulate a number of different neuroimmune factors in terms of neuropeptides, etc., other inflammatory cytokines. This may, in fact, lead to heightened sensitivity to stimuli. This has been a big hypothesis with respect to the link to attention deficit disorder, why they're hyper-attentive in particular, and it's one that has a strong basis in terms of animal models and translational research. Poor sleep is another important one, especially for those symptomatic diseases, because sleep disturbance has actually been shown independently to be a risk factor for essentially all of those psychiatric disorders. And you could argue that, when you're studying for, cramming for finals, you have to take the recert exam, and, you haven't slept in a few days, you become a very cranky person. Now, is that really are you depressed? Or is it just that's the chronic effects of sleep deprivation? I mean, it may be semantics. The bottom line is, for these chronic disorders where they're highly symptomatic, this is something that they're living with on a daily basis. And so again, this idea of targeting sleep as an important endpoint and trying to improve that for patients may not just improve their overall quality of life, but may have major impacts on the downstream sequelae of these disorders. It may very well be related to chronic itch and pain, inflammation, the degree of atopy that happens in some of these disorders. When we think about atopy and the connection with skin disease, it is by no means limited to atopic dermatitis. Numerous studies showing associations between allergic disease and alopecia areata. Numerous studies showing relationship between high IgE levels in bullous pemphigoid. And in fact, it is now thought in bullous pemphigoid that IgE may be a very important causal driver of the disease severity. So it may very well be that atopy underlies a lot of this and is common sort of pathway or mechanism involved in all of this. And so I would encourage you to be thinking about this not only in the skin side of the atopic spectrum, but really throughout the entire spectrum of things in terms of airway, etc. So let's talk about the atopic comorbidities. And I'm going to gloss over this relatively quickly because I just mentioned, I sort of preempted it a little bit, but these are data that overall, conceptually, you're going to be quite familiar with. This is an audience I don't have to preach to about the connection between atopic dermatitis and respiratory atopy. But suffice it to say, we have significantly higher odds of the entire spectrum of atopic disease, asthma, hay fever, and food allergies in those with eczema indicated in red compared to those without eczema in blue. And these are data from the National Survey of Children's Health, really giving a population-based answer around how common these disorders are in childhood eczema. And what's remarkable is that these numbers actually are virtually identical in adults as well. When you look at the U.S. population from National Health Interview Survey, different study design, slightly different questions, and yet almost identical prevalences with about 1/4 lifetime history of asthma, about 20% with current asthma, and 1/3 with hay fever throughout the population. The food allergies, again, take with a grain of salt. Obviously, they're going to be more common in those with atopic dermatitis, but there's no way they really have 15% of food allergies there. And we've seen this from the NHANES study that the self-report doesn't necessarily link up to the skin prick positivity. And of course, that's the bane of the existence of almost everyone in this room. That's also why you have a job, is because all these people have food allergies, and then it turns out that they don't. But what we see is a clear-cut association between severity, first of all, between the presence of atopic dermatitis and the severity of those comorbid conditions. And so in the lighter colors, you have the group with eczema, the darker colors, those without. And this is looking at the severity of the comorbidities. So red being severe, green being moderate, blue being mild. And what you see is that in those with eczema, you have a thickening of that red bar and a thickening of that green bar. And so you have more severe overall asthma, hay fever, and food allergies. And the direction actually goes the other way as well, where the more severe the atopic dermatitis is, the higher the proportion of patients with those atopic comorbidities, and the more severe the atopic dermatitis, the more severe those atopic comorbidities. Now, that does not at all tell us the chicken or the egg, and for the past 50 years, there's been this debate about is it all IgE mediated or not, and what those mechanisms are for the atopic dermatitis. Are they all one shared pathway? I show you this, and again, many will be familiar with these data, but this is a very elegant study in terms of really prospectively examining that how atopic dermatitis may precede all those food allergies. We have all of our patients who walk in the door and swear that their atopic dermatitis is all a food allergy, and they're looking for, out here I'm sure it's gluten is the devil that causes all the problems, but in Chicago it's not all gluten, although a lot of it is, but everyone's grasping and looking for foods that are really challenging. And as it turns out, it's not that simple to say that atopic dermatitis is a food allergy, but the reverse may very well be true, that the atopic dermatitis predisposes. So, this is a study that looked at 600 exclusively breastfed infants at 3 months. So keep in mind, these kids have not eaten any of these foods, and found that atopic dermatitis was associated with a 6-fold higher odds overall of a positive skin prick test to foods. And particularly, moderate to severe disease using an objective outcome, the SCORAD, Scoring Atopic Dermatitis Index, is one of the sort of vetted pseudo-objective assessments around since the 90s. And looking at the definition of moderate to severe disease, a 25-fold higher odds. You very rarely see effect sizes like that in epidemiology studies. That is a very strong association. And versus in the milder group, still have a significantly increased odds, but not quite as much. And around a 4-fold increased odds. Not surprising, eggs, cow's milk, and peanuts were the most common allergens, but those are usually the most common allergens. And what's fascinating here is when you think about peanuts and you start thinking about some of these allergens, they're not eating them. Some of these are a little heavy, so it's questionable whether or not they're actually inhaling them. And so it raises some real questions. It's possible they're getting it through the breast milk, but it raises some very interesting questions about transcutaneous sensitization through that broken down skin barrier and how that impacts things. And so this is, of course, part of this whole concept of the atopic march. This atopic march has been challenged again and again because we see patients where they may have later onset asthma, or they may have asthma in the absence of any demonstrable skin disease, and we don't know what to make of that. Maybe they had skin disease and we forgot about it, but it's something that really raises some important questions about how atopic dermatitis may precede the allergic disease. I'm going to go through this fairly quickly. There's been some really, the old dogma about allergic contact dermatitis, and this is going to be very clinically relevant, for everyone in this audience potentially. But the old dogma was that in the U.S. population, or in the general population, that you had no increased risk of allergic contact dermatitis in those with atopic dermatitis. And the reason is you would have competing effects. You'd have the broken down skin barrier that would allow all the sort of junk of the outside world, transcutaneous penetration, and then you'd get sensitization that way. But on the flip side, you have that old yin-yang of Th2 versus Th1, the idea being atopic dermatitis is all Th2, contact dermatitis being all Th1, they'd offset each other, and in fact you'd have no really greater difference between the rates of allergic contact dermatitis in those with versus without atopic dermatitis. And it turns out this may very well be wrong. So we have now multiple studies that have shown higher rates of allergic contact dermatitis in atopic derm, and some previous studies have estimated the prevalence of allergic contact dermatitis in wide ranges, anywhere between 15 to 65% in children in particular with atopic dermatitis, and often the relevance being very high when you find a positive allergen on patch testing. This is just a study that has tried to examine what are some of those common allergens that happen when you patch test children with atopic dermatitis. So a smaller study looking at 82 children with atopic dermatitis, and found that about 1/4 had a positive patch test. And one group in particular that was very high risk were those that had in particular hand or foot dermatitis with a strong predominance there, had at least one positive patch test, about 40+%. And the allergens that we see here are fascinating because we have nickel there, but it's actually not nickel at the top the way it is for everyone else. You actually see at the top Amercol. Amercol, for those of you who may not be familiar, is lanolin. Lanolin is wool alcohol. It's an emollient. It's used in everything, including Aquaphor and a ton of different lip balms, you name it, all these different things that consumers are using all the time in daily personal care products, and sometimes in things that we're actually recommending them to use when they have atopic dermatitis, and we want to give them recommendations of things that are safe. But in fact, when they're repetitively getting exposed to these allergens, may develop allergic contact dermatitis to them. And then, of course, we see fragrances toward the top, and then the dreaded methyl isothiazolinol, methylchloroisothiazolinol, which is, we call it the epidemic in the world of contact dermatitis. And what's fascinating here is that we've started to see now more well-done studies on the mechanisms of atopic dermatitis, and it turns out it's not all Th1. Yes, there's a Th1 signature, but it's far more complex. Some studies have even shown a Th2 signature in a subset of allergic contact dermatitis. But Th9 cells and Th17 cells have also been shown to be upregulated in many atopic dermatitis patients. And interestingly enough, Emma Gutman in Mount Sinai in New York has also shown upregulation of some of these pathways in atopic dermatitis as well. This could potentially be a common pathway for why some patients have both. And so it's an intriguing issue around shared mechanisms and how this develops.
So do you patch test little kids with eczema?
I do, but they're not always easy to patch test because you have to, the logistics of it have to work out. They have to be clear enough off of topical steroids for a week or off of systemic for essentially a month, and enough body surface area to work with, but absolutely.
And then do you make your own patch test, or do you, because the true test doesn't even include the lanolin?
Correct.
So
That is correct. The true test doesn't include a lot of this stuff.
Right.
And
do you make your own up?
Yeah. So I use. So I'm part of the North American Contact Dermatitis group. So we use much more expanded patch testing series. Depends on the size of the child, because it's not always feasible to put the full screening series of 70 on there. Nor do we even think that they're all relevant in kids the same way they are in adults. But there's a more trimmed down series of about 30 for the kids, which has a completely different allergen profile than the true test. And so, yes, and you can, and actually all the studies that have done patch testing in atopic dermatitis in children, or in children in general, have indicated that we are far too shy in terms of how often we patch test our children. I'm not recommending, mass patch testing to every child out there, but, oftentimes the same patterns we see with severe adult atopic dermatitis and refractoriness being driven by an allergen are true in kids as well, and something that we should be thinking about more.
So how do you order this 30 allergen? What's it called?
So there's no official name for it. It's just you can actually look. Where would you find this? So I'm part of the group, so I have the short form for how they do this. Where would you find this online? You may not. Actually, you'll just find it in their literature. If you look for any recent publications that have looked at the pediatric versus adult positive rates in children from the North American Contact Dermatitis group, you will see them. There's also some new data that has come out from something called the Pediatric Contact Dermatitis Registry, which is run out of by someone named Sharon Jacob at Loma Linda. And it's a nationwide cohort, and they've published some data in dermatitis and JAMA dermatology as well, looking at which allergens are most common in general in children, but in particular within atopic dermatitis. And so you can use that to sort of guide your decision making. I think the hardest part about it is it depends on the volume of patch testing. So I run the contact dermatitis clinic at Northwestern, so I patch 10 to 15 a week, patients a week. So we go through our allergens efficiently. But when you're not and you're making up your own patch testing, a lot of stuff can expire and go to waste. So you have to just think about what strategies work for you without breaking the bank and causing you as a practice to lose money. But yes, it is highly encouraged to patch test if it's feasible. And we'll talk a little bit about what the recommendation. Actually, I don't know if we're going to talk about the recommendations, but I might as well talk about it now because I think we're running close to the hour, and I feel not at all compelled to go through all the slides. So I'd rather talk about stuff that's of interest. But there's no evidence-based guidelines for patch testing in atopic dermatitis. It is all consensus-based, but based on the consensus guidelines, there are some common themes that have come up. So one, for adolescent or adult onset atopic dermatitis, I firmly believe there is a true entity called adult onset atopic dermatitis. We have a paper that's, I think it was just EPUB'd in JACI in Practice, looking at adult onset atopic dermatitis and predictors and phenotype. But for many of these, it's just contact dermatitis, and you have to keep that in your differential diagnosis. If you have localized distributions, the predilection for the hands or feet, like I showed you in that one study, but really, anytime it's one-sided, it's predilection for certain areas, it really makes you wonder if there's some contactant that's hitting it in that area, which would be true for any case of contact dermatitis. Severe refractory disease, so if they're refractory to topical therapy, they're just not behaving the way you would anticipate them to. You have to think about a possible contactant that might be driving it. And if you're about to put them onto a systemic agent, you're thinking of going the route of a dupilumab, a cyclosporin, whatever it might be. You want to see if you can find something that's reversible first before you push the issue of potentially months or years or lifelong systemic therapy. And so it is worthwhile to look. You're not always going to find it. That's the reality of patch testing is it's often negative, but it is deemed a good idea to do in the field. The other scenario that I see, which is not part of the guidelines, but I recommend based on the other patch testing literature, is if you see nummular eczema, a strong nummular phenotype. So many of our atopic dermatitis patients will have nummular lesions, coin-shaped lesions. And that can still be true atopic dermatitis without any allergies. And it's more common in adults, particularly with adult onset disease. But we know from the patch testing literature, in general with idiopathic nummular eczema, that you can have rates of positive patch testing up to 40% or more with some really relevant allergens. So when I see that extensive nummular phenotype in atopic dermatitis, it also will prompt me to think about patch testing in those cases. Yeah?
About patients with just hand dyshydrotic eczema.
The patch test.
Yes, I mean that would be independent of this whole discussion of atopic dermatitis. But again, that's that localized distribution. I mean, it's always a good idea before you jump to patch testing to work on the skincare and try to manage with a topical steroid first, because frankly, if all they have to use is mid-potency topical steroid once in a blue moon, even if it is driven by an allergen, I'm not sure it's worth the cost and the process of doing it. Yet, when they have that chronic refractory disease, you bet. It is definitely a worthwhile way to go. So I'll summarize the next few slides rather than go through all the data, but just to tell you that, as I mentioned already, vitiligo now across multiple studies has been shown to be associated with allergic disease, asthma, hay fever, food allergies, etc. And this is something that has been shown actually high rates of comorbid atopy in those with alopecia areata as well. And so even within what are deemed to be autoimmune skin diseases, without the atopic dermatitis, we still see that connection with respiratory atopy as well, and even more severe disease in those with atopic dermatitis as well, higher rates of alopecia totalis and universalis, which is sort of the full body loss of hair, and more severe disease when you have the comorbid atopic dermatitis. And so for the mechanisms here, we certainly think about barrier disruption, the immune dysregulation. There may also be an unmasking of the underlying predisposition by scratching, where you may actually have a kepnerizing phenomenon in the case of vitiligo when they have atopic dermatitis or itchy skin disease and they scratch the heck out of their skin. They get this secondary kepnerization where the vitiligo may flare up. And then, of course, this also may be due to detection bias, because when you have patients with one skin disease, they're going to see a dermatologist, they may get picked up with others. But it seems to be true across any way you look at this, that this happens to be the case. I think for the sake of, what time do we have to stop? We have a hard stop like 4 minutes, right?
About 5 minutes.
Okay. So I'll skip through the autoimmune comorbidities because I think it's cutting edge, it's novel. It suggests some fascinating issues that even within atopic dermatitis, it's not just the atopic comorbidities that we may need to think about, but there may also be associations with a number of other autoinflammatory or autoimmune disorders. Some provocative data showing higher rates of rheumatoid arthritis, Crohn's disease, ulcerative colitis as well. I mentioned already the link with alopecia areata and vitiligo, which would be considered sort of classical autoimmune skin diseases. But even seeing higher rates of thyroid disorders with vitiligo and a number of other pernicious anemia, type 1 diabetes, a number of other autoimmune disorders, systemic diseases. With psoriasis, we certainly have seen this, higher rates of multiple sclerosis, ankylosing spondylitis. There may be shared mechanisms that come up with these patients. And then last, I'll touch upon the issue of cardiovascular disease, because this is one that we actually may be able to modify in our patients. All right? And this is going to be multifactorial, but I'll start with psoriasis, which is the most vetted and well-established. But a meta-analysis of 75 studies showing highly consistent associations with every type of cardiovascular disease you can imagine. Ischemic heart disease, atherosclerosis, diabetes, hypertension, metabolic syndrome, you name it. Some studies, other meta-analyses have been done that have confirmed this. We've done a meta-analysis as well looking at atopic dermatitis in particular with obesity, and found that similar to psoriasis, you see the same association between atopic dermatitis with overweight and obesity in children, in adults, across multiple study designs. Even when you control for a variety of different areas, it all holds up to be true. And then this is some data that we published in JACI a couple of years ago, looking at National Health Interview Survey 2010 and 2012, two different cohorts, showing much higher rates of cardiovascular risk factors. So poor health behaviors, more likely to smoke, greater amounts of smoking, alcohol consumption, sedentary lifestyle, and then not surprising higher rates of hypertension, diabetes, hyperlipidemia, etc. And when we actually looked at, this is one study that showed that when we looked at 3 different cohorts, so NHANES National Health Interview Survey 2010-2012, across all 3 studies, higher rates of heart attack, stroke, peripheral vascular disease in these patients, as well as angina and some of the underlying, the first stages. So this is something that will remain controversial. Other studies have come out that have confirmed this. Other studies have come out and said, yes, it's there, but it's not related to the atopic dermatitis. It's related to the fact that they're obese and other things. But this is a real issue that comes up, and we're starting to see this now with a number of other issues. So the things you want to be thinking about is, there's a lot of mechanisms that are driving this. It may be partially related to inflammation, But I'm a big believer here that you have to think about behavior. And this is one of those scenarios where, it's like first year medical school. Even that 5-second intervention to tell them not to smoke. If you do it enough, it eventually may sink in. This is where we can really be effective, because in our patients, you're going to see higher rates of these poor health behaviors, and there's things that we can modify. The other thing is to keep in mind, for patients who are itchy, you're used to thinking about this in asthma, but if they wheeze because they exercise, they don't move. So something that you have to work on is getting enough control of the airway so that they can actually exercise. The same is exactly true in atopic dermatitis. Heat and sweat are the most common triggers of itch. So they do everything they can to avoid itching. They won't go to the gym, they won't exercise. So this is where you may need to step up your level of control in order for them to be able to exercise and improve those lifestyle issues. And so with that, if there's anyone who wants any additional questions, I'm happy to take them.
Do you have any evidence that treatment makes any difference in altering these comorbidities?
So that's obviously the next step where this all goes. I think for some of these, we still need confirmation even on the retrospective studies first. What we do see are dose-response effects, which are right now the most telling, that if we can lower the severity, that we should be able to improve it. The problem is that once the cat's out of the bag, it may be impossible to get some of these back in. Meaning, it's one thing to show that more severe disease is associated with it where mild disease is not, but the problem is, maybe if they've had severe disease for 3 years, or 5 years, or whatever that magic number might be, the risk is irreversible. And so that's the part that we don't know yet. We do see improvements of the sleep disorders in terms of the fatigue, the daytime sleepiness, the insomnia, stuff like that. And actually, across many of the new trials that you're starting to see in the atopic dermatitis pipeline, sleep is becoming an important endpoint because it is modifiable and has been modifiable in recent studies as well. The challenge is that's for when they have symptoms that are directly related to the itch, in the case, let's say, of atopic dermatitis, or pain in psoriasis. But what happens now when they have something like an obstructive sleep apnea? Can you reverse that? It's not so easy to reverse obstructive sleep apnea. Once they have it, with immense amounts of weight, modification, yes, you can, but it's not always reversible in that sense. So it's, these are challenging things that will come up, and I think this is why over the next 20 to 30 years, you're going to see more and more a shift in the way we think about this, where we're often very cautious about managing our younger patients, or over-managing our younger patients because we're worried about safety concerns. But I think now, as we understand the systemic nature of these disorders, more and more you're going to start to see discussions of what happens if you execute a stronger treatment early on in life. Can you prevent the atopic march? That's a conversation that's happening already, and there's studies that are NIH-funded looking at that. What if you're a little more aggressive? What if you use different treatments, get better skin control, or systemic agents? Could you modify those? So we'll see that soon for the atopic march. I think we have a lot more to go to see for these other comorbidities. My gut says probably yes. It's just not always so easy to get good control in those more severe patients and to maintain it. Just getting control for 3 weeks may not be sufficient in these patients. It's a tricky scenario. Yes?
When you have so many comorbidities, I'm sure you're going to find relationships between like cardiovascular disease and mental health issues, etc. It's really difficult to sort out which comorbidity is the one that's really important. And it makes me think there must be some overall problem that's poor protoplasm or something like that that's really accounting for all of these. Have you had any luck?
We started to try to look at this not at the mechanistic level, but at the phenotypical level, and how these disorders cluster together. And the answer is absolutely yes. It is virtually impossible to distinguish between the impact of sleep and mental health, because they're almost one-to-one correlation. If you want to know who your depressed patients are going to be, who your anxious patients are going to be, it's the ones who are not sleeping.
Right.
And they're floor effects. Not everyone gets those sleep disturbances, despite how intense their itch are. For some reason, some sleep better than others. And so, yes, we start to think about what pathways are different in those patients. Is it because they have upregulation of IL-6, which is the one that's been shown to be involved in sleep before? Is it because there's other behavioral factors? We just don't know at this point. But there are a number of studies that are looking at this. We're actually trying to do some translational work now, where we're able to look at both a variety of different tissue samples, blood, etc., and link that up with the prospective outcomes, the sleep disturbances, the mental health. But I've learned the hard way, it's really hard to distinguish between those two. But let's say you lump those together, sleep and mental health together, and you assume that they come as a package deal. You see for almost all of those cardiovascular comorbidities, clear-cut interactions where those who have the atopic dermatitis plus the sleep disturbances, dramatically higher rates of those cardiovascular risk factors compared to those without the sleep disturbances. So that's why I think, and so I'm a little, I don't want to say biased because these data drove us to create a multidisciplinary eczema clinic together with allergy and with sleep medicine. And sleep medicine is a huge part of the equation because that's really hard to treat. And even when I get good control of their skin disease, the sleep stuff may just be permanent because of all the bad habits and everything else. So without having a partner in sleep medicine to help these things, it's often very challenging to get good control. And some of this stuff is stuff that you're comfortable using. It's not necessarily systemic immunosuppressants. These are things that really work quite well in the sleep medicine world. But I think that we'll start to see longitudinally that as we're able to get better control of sleep in different cohorts, we should see reductions of these different
So if you think of first causes, are you looking at any genetic kinds of ideas?
So we are banking for genetics. We haven't yet looked at to see what the data have shown. We want to do them in batch, and obviously for the genetic studies you need a lot larger samples. We don't have any sense yet of the genetics completely. What we do have are some studies that have suggested that there may actually be a mutation in one of the CARD genes that's found in Alopecia Areata, that in those patients with Alopecia Areata who have sleep disturbances, and it's possible that that may also play a role in the atopic dermatitis patients. So it could just be that it's not actually exclusively the atopic dermatitis, but it's a multi-hit model. So maybe you have the filaggrin, that causes all the atopy, and you're itchy like crazy. And that's going to make things bad. But now you throw in some other CARD mutation, and now you have a predisposition to messed up circadian rhythms and sleep, and now you have both of those, and you're really, you're in trouble at that point. So I think we're starting to move away from the idea that it's all just filaggrin, because we can't reproduce filaggrin in 70 to 80% of our patients, the filaggrin gene mutations, even though they all have downregulated filaggrin in the skin. But more importantly, is that we're starting to see studies that are showing mutations of kallikrein, interleukin-18, TLR2, all kinds of other pathways. And there's actually some interesting data from different groups that have shown multi-hit models, so that if you have filaggrin gene mutation and a TSLP mutation, they may have competing effects and less severe disease. Versus if you have, an IL-4 mutation plus a filaggrin mutation, your risk is through the roof for atopy. I think we're going to see a similar scenario where it's going to have a polygenic effect on those comorbidities. But what do you do about counseling? That's a whole separate ballgame. But we first have to show it. So.
All right. Well, thanks very much, John.
My pleasure.
Very good.
There you have the cover slide. Word of the day: skin.
Oh. That's if people want CME credits.
I got you. Okay.
They don't get CME. All right, you got it right in here.
Yeah, we're good. I'm actually probably I left my bag at the hotel. I have plus some time. So
Is your code?
that is my code. Yes. Pleasure's mine. I think you're starting to see for respiratory illness, obviously the sleep disorder, breathing, and all these other things are such important issues. So it's interesting to see where it's going because the pathways that are being implicated are very provocative, far more advanced than what we know about this.
This actually just expands.
And it's an interesting issue that comes up because I almost think of this as, in a sense, advocacy, because I find we encounter this. We certainly encountered an asthma fever as well, where you have some branded medications, really expensive. Payers just and they don't want to cover it. And what they don't realize is that there's indirect effects And if you can modify the disease, you may be saving a fortune on antidepressants and other things like that as well. So they're not used to thinking, right? And so I think we need more and more IgE. Exactly. That's exactly right. We need to understand more of the global situations and recognize that we may be accomplishing much more than just a little less sniffy.
It would be really nice to find the highest cohort of people that are absolutely hungry for peace.